by Dr. Avinash Upadhyay that patient after VRD 5 cycles had stringent CR and beam maintenance relapsed after 9 months after the VRD 5 cycles. Now on pomalidomide. So even with the 2 milligram pomalidomide was having the cytopenias. So what should be done in resource constrained world? Can we rechallenge with the VRD as she had stringent CR post 5 cycles VRD? So basically this patient is pomalidomide intolerant. So can I request Dr. Ajay Agarwal sir to highlight about this query?
So relapse setting, may I request Dr. Nupur?
Yeah.
Sure. No, this is a common problem. But before talking about relapse, I think the important thing to remember for myeloma is, we should be continuing therapy. So don't stop at 5 cycles of treatment, even if they've achieved a stringent CR. I think the one thing we've learned about myeloma is continuous therapy is important, or maintenance treatment is important if they haven't had anything else. So continuing with the Velcade and lenalidomide at the lowest possible doses would have been the right thing. But in this case, absolutely, I think since they've been off of a proteasome inhibitor for some time and have been off of lenalidomide, she's probably going to be sensitive. Going back to RVD would be perfectly reasonable, but then not stopping after they've achieved a response is the key. If, on the other hand, they do not respond, you do have the option of adding a monoclonal antibody like CD38, like daratumumab, with bortezomib as well. So lots of options here, but continuous therapy is critical in this patient.
So there is another question which is directed to Dr. Nupur Raje from Dr. Manoj Mahajan. He is a senior medical oncologist from Udaipur. So Dr. Manoj is asking that does copy number of 1Q changes poor prognosis imparted by its gain? And the second question is, does bortezomib and daratumumab and 4-drug regime in newly diagnosed multiple myeloma negate its poor prognosis? And continuation to this, he has also asked that if there is any evidence good enough to consider it prognostic marker, as most of the studies are done on very small number of the patients. So basically his question is about the 1Q gain, where the copy numbers matters or not, 1, 2, 3 or 4, or all are high risk.
So all good questions here, and I don't think we have all the answers. The fact that gain in 1Q is becoming more of a prognostic marker is real, and we are considering this as a high-risk feature going forward. Copy number does matter, and more than, it's a cutoff for that specific lab. We take more than 10 as considered, at least at our lab, but copy number absolutely makes a difference. With 4-drug regimens, the second question was, does it negate the high-risk features? The data that you've seen with 4 drugs, like the Griffin trial RVD with daratumumab, or Cassiopeia, which is VTD with daratumumab, we've seen very high response rates, 100% of people responding with high MRD negative disease as well. I don't think these are largely, the high-risk patients are also doing fine. I don't think we've seen data to say the 4 drugs does better in the high-risk patient population compared to the 3 drugs as well. So the 4 drugs does negate some of the high-risk prognostic features. With the Griffin, we still have to wait because we've not been able to look at high-risk cytogenetics versus not. Responses are deeper for sure, but toxicity is also higher when you start combining so many drugs together.
Thank you very much, Dr. Nupur. Can I, Dr. Manju is logged in with us or not? Is Dr.
Ma'am is there, sir.
Yeah, Dr. Manju?
Yeah, I'm there.
Yeah. So there is one question from Dr. Dipti Rani Samantha, that she has asked that what is the ideal maintenance therapy in transplant ineligible patient?
So again, we need to look at first, what's the reason for being ineligible? And, if it is not somebody really frail and it's just the age which is the reason, then in that case, one can still think of a triplet that's what we would suggest. But if it is somebody who's frail, then in that case, doublet can be considered. And definitely we need to take in consideration whether it's what are the additional comorbidities and which are the drugs which are going to be, tolerated by that particular patient.
Okay, thank you very much. Can I ask Dr. Agarwal that what is the difference between daratumumab and daratumumab with hyaluronidase, FIHJ, and in considering the clinical response? So, sir, can you?
So basically, it is using daratumumab by two different routes. When you are giving it an intravenous infusion, it is dara alone. But when you are giving it by subcutaneous route, you have to give it with hyaluronidase. That's the preparation. It's a spreading agent. The huge advantage of subcutaneous route is the time-saving part of it. Something that you take hours, you're finishing in minutes, and of course the reactions are also less. So subcute route is with hyaluronidase, IV is without hyaluronidase.
So, Dr. Upendra, are you online?
Sir, can you hear me?
Yes.
Yeah, you can continue, Dr. Upendra, asking the questions.
Sir, I'm really sorry. There
No
was some
issue, no
problem
issue,
with
carry
this.
on.
So I
Carry on.
have logged in with a different laptop. So
Carry on, please.
Sir,
You will start from the Vibhor Sharma. Question from Dr. Vibhor Sharma.
Vibhor Sharma. So this is question from Vibhor. How do you define refracting? This is question to Dr. Manju Sagar. How do you define refractiness to bortezomib and lenalidomide? For example, if a patient received 4 to 6 cycles of RVD, then he was transplanted, and then he received this lenalidomide maintenance and relapsed down the line. Can he still be labeled as refractory to bortezomib? So he received 4 to 6 cycles of RVD, initially bortezomib for 4 to 6 cycles, then transplanted, then received lenalidomide. So can once he is relapsed, can he still be labeled as refractory to bortezomib? Dr. Manju?
No, I don't think he's. Yeah, I don't think he's refractory to bortezomib. When we talk about refractoriness, it's a progression within 60 days from the last treatment, whatever is the last treatment ongoing. So here the RVD was given before transplant, and the progression has happened on len maintenance. I don't think that this is called as refractoriness to bortezomib.
Thank you. So another question from Satyajit Pawar. So question to Dr. M.B. Agrawal, sir. A 60-year female, multiple myeloma, revised ISS-1. She received 6 cycles of VRD and achieved stringent CR and planned for autologous stem cell transplantation, but this was delayed due to personal reasons, and she relapsed on lenalidomide maintenance received for 3 months. So now workup done, FISH is negative. She received VPD 4 cycles, and post VPD 4 cycles, she is in stringent CR. So what is the optimal consolidation strategy for this patient in this COVID era?
So if the COVID era is interfering with autologous transplant for her, you'll continue with the triplet for a total of 8 to 12 cycles. And by that time, I suppose you may be able to do transplant, but you will at least have the stem cells preserved immediately.
Thank you, sir. Thank you very much. Another question from Dr. Neha Ganju. This is question to Dr. Nupur Ajay. In high-risk myeloma patients who are eligible for transplant, what is the upfront DARA-based regime? Is there is role of DARA-based regime in standard risk transplant eligible patients also?
So again, a good question. The data for the transplant eligible patients with DARA include both Cassiopeia as well as Griffin. So the European study had daratumumab with Velcade, thalidomide, and XVTD. And the Griffin trial has DARA with RVD. So you can consider using either or. Right now, I will tell you that even I'm not using 4 drug combinations outside of a clinical trial. because I think the data with the 4 drugs is still early, and it does, compound toxicity as well. And we are seeing very deep responses for sure. But does everybody need the 4 drug combination? It's a little bit unclear right now. Triplets are still working just as well. So RVD and KRD work fine. There may be a case made for the high-risk patient to add on the 4th drug, which would be the monoclonal antibody.
Thank you, Dr. Nupur. Now my question to Dr. Manju Sehgal. How do you evaluate relapsed myeloma? Again, from question from Dr. Neha Ganju.
So we actually, we monitor, so the relapsed myeloma can be just serological progression without having any of the end organ damage. So we need to evaluate for the end organ damage. We need to look at how the first presentation was based on, to decide whether you want to just treat on the basis of how the serological progression is happening, how rapidly it is happening. If you have the means, other than looking at the end organ evaluation, one should consider doing a marrow at this time and evaluating cytogenetics and FISH. So that's what we would suggest if you have all the means available to you.
Okay, thank you. Another question from Raj Kiran. This question to Dr. M.B. Agrawal, sir. For a case of 65-year case male, standard risk newly diagnosed multiple myeloma, transplant eligible, but unwilling for autologous stem cell transplantation. This patient had received 16 cycles of VRD, and electrophoresis after 16 cycles showed good response. So what should be the next line of therapy?
So even if he's not willing for the transplant at the moment, I will still persuade him to store his stem cells. And then if the response is satisfactory and he's already received 16 cycles, I will now go over to the maintenance therapy. And if the response, this good response, I do not know what exactly it means, but if it is not a satisfactory response, I'll maintain him with low dose VRD, but maintenance therapy, yes.
Okay, thank you, sir. Now my question to Dr. Nupur Raje. This is question from Dr. Neha Ganju. Is autologous stem cell transplantation is indicated after CAR T cell therapy?
It's tough because we are doing right now, CAR T cells is happening at very end stage myeloma. So those are not patients who you would consider doing an autologous transplant. Having said that, we are now doing clinical trials early on. We are actually replacing autologous transplant with CAR T cells in high-risk myeloma. So high-risk cytogenetics, they can get initial induction followed by CAR T cells, and we'll see what that data looks like. We have not given autologous transplant post-CAR T cells as yet.
Thank you. Again, a question to you, Dr. Nupur. This is question from Dr. Akshay. Is there is any way to enroll patients of lymphoma, myeloma, or leukemia for CAR T cell therapy trial anywhere in the world? So how we can enroll our patients from India?
Yeah, so, again, good question. We do have a lot of clinical trials available. The problem is they will have to come here, and with what's going on with COVID, all restrictions apply all over the world. So that's not happening. But otherwise, we have treated people from outside the US on clinical trials. And I think in the COVID area, it's less likely. Having said that, I'm working very closely with an Indian company, Immunil, to try and get CAR T cells to the Indian patient population. And we are working for lymphoma as well as myeloma. And our hope is that we will get CAR T cells to patients in India.
So this will be the last question.
Thank you very much.
Upendra, this
yes,
will be the last. This
yes,
will
sir.
be the last
question. Yes, yes. So this question is to Dr. Manju Sehgal. Again, question from Akshay. Any prognostic significance of different heavy chain myeloma, IgA, IgG, and IgM? Or there is any significance of uninvolved heavy chain levels? Are we getting this report in our gel electrophoresis report?
I think with the current prognostication systems, if you look at the subtype of different heavy chain myeloma, I'm not sure that it, maintains its significance with the cytogenetics and the revised ISS. There is no clear data on that with the current prognostication. There is some suggestion in terms of this involved versus uninvolved heavy chain levels, but again, not something which is proven in terms of prospectively done clinical trials to say that what is its relevance.
So
thank you, ma'am.
With this last question, we come to the end, and my heartfelt thanks to Dr. Nupur Ajay for sparing time out of your such a busy schedule. And in the same breath, I extend my heartfelt thanks to Dr. M.B. Agrawal sir and Dr. S.H. Advani and Professor Manju also for sparing time for this webinar on multiple myeloma. And now I hand over the mic to Mr. Manoj Kumar from INTAS Oncology to conclude the session.
I think, sir, it's an honor and privilege to have the coordinator role along with the MICE team. Firstly, I would like to thank Dr. Ajay Bapna for giving us this opportunity and giving us this academic feast. All the leading experts in the field of myeloma, Professor Manju Sengar, Dr. M.B. Agrawal, Dr. Nupur Ajay, and expert comments by Dr. Advani. I think it was an academic feast. I would also like to thank my team at INTAS for all the hard work, and team at MICE Ideas for all the hard work in terms of coordination, which was running almost for a month or so. So thank you very much. Have a wonderful evening. And for you, ma'am, have a wonderful morning. Thank you very much.
Thank you
Thanks
very
so much for having me. Appreciate it.
Thank you so very much. Yeah.
Thank you.
Thank you.
Thank you, sir. And we take your leave. Thank you, Dr. Upendra.